Okay, now let's discuss about the Conn syndrome. Conn syndrome is called when there's a primary or there's an increase in aldosterone levels due to adrenal adenoma. Okay, this term is specifically used for adrenal adenoma. But the most common cause of increased aldosteronism, that is hyperaldosteronism, that is because of the bilateral adrenal hyperplasia. Okay, so the features in Conn syndrome will be there will be diastolic hypertension, but there won't be edema. Okay, there won't be ascites or pedal. With that, the patient will be having polyuria and polydipsia, and there will be hypokalemia, which will lead to severe muscle weakness. Okay, in ABG we'll see metabolic alkalosis because the protons are lost, the hydrogen ions are lost. The strongest differential diagnosis of Conn syndrome is the Liddle syndrome. There's a gain of function of iliac channels, and the treatment we give is amilorides and trimeteret of the Liddle syndrome. There's something called aldosterone escape phenomenon. What happens in that? In spite of increased aldosterone, that will cause sodium and water, but there is no sodium and water retention. Okay, why this happens? Because there are multiple mechanisms. Because there's increased renal perfusion pressure, the sodium is reabsorption is decreased in the proximal convoluted tubules. Okay, now investigation of choice is oral salt solution test. We can also use aldosterone by renin ratio, that is for screening, and it is only for primary hyperaldosteronism. Treatment to choice is surgery. If it's unilateral, bilateral, you have to go for drugs like spironolactone and eplerenone. So this is a flow chart, easy to understand. When we have a suspected case of hyperaldosteronism, like features are like severe hypertension, even if the patient had put on more than 3 drugs, antihypertensives, and if there is hypokalemia, adrenal masses are there, family history is there, like early onset hypertension or cerebrovascular accident, that's a stroke at less than 40 years of age. Then for screening, as I said, we can go for aldosterone by renin ratio. Okay, if it's more than 750, then it's diagnosed. Screening is positive. But for the test, what we have to do, you have to stop the spironolactone for 4 weeks, and you have to correct the hypokalemia. Only then we have to calculate this ratio. Investigation of choice, you can go for saline infusion test. That is, we have to give 2 liters of normal saline, 0.9%, for 4 hours, and then check the aldosterone levels, plasma. If it's more than 5 to 10 nanograms, then the test is positive. Similarly, oral sodium or salt loading test, you give oral salt for 3 days, and then you see for 24-hour urine aldosterone. Then a fluorocortisone suppression test, you give 0.1 mg tablet of fluorocortisone QID, that is 4 times a day for 4 days, and then you check the serum aldosterone, which is more than 6 micrograms, then the positive. Captopril challenges, similarly 25 to 50 mg you can use. After 1 or 2 hours you can check the serum aldosterone, which should be more than 5. Okay, so these are all suppression tests. We are trying to suppress the aldosterone. If it's not getting suppressed by all these methods, then we see it's a primary or hyperaldosteronism. Okay, now after this, the test is positive, then you go for CT abdomen, that is adrenal glands, and you decide if it's unilateral, you go for adrenalectomy. But if it's bilateral or the age is 40 or the surgery is not feasible, then you start on drugs like spironolactone or even eplerenone and amiloride. So this is the approach. Thank you.